Good morning, everyone. It's 8 a.m. on a Wednesday. Thank you very much for joining us. And we will get started. Some people are still streaming in, but once we get started, most everyone will be here. So good morning and welcome again to another installment of our Princess Margaret Hospital CME. If you're not driving, I invite you to close your eyes, take a deep breath, giving thanks for another day, focusing on today, focusing on the moment, and focusing on the present and why we are here. Breathing out, opening your eyes, let us begin. So today we have the distinct pleasure of being joined by Dr. Anishka S. Rolle, who was born and raised in Nassau, Bahamas. She is board certified in internal medicine and rheumatology. She completed medical school training at the University of the West Indies, and so is no stranger to any of us, and then went on to complete internal medicine residency training at the Carillon Clinic, Virginia Tech, and subspecialty training at Roger Williams Medical Center, Brown University, respectively. Dr. Rolle is also certified by the American College of Rheumatology in Diagnostic and Therapeutic Musculoskeletal Imaging. She has dedicated her practice to the specialized field of rheumatology and integrates all aspects of care by collectively combining her knowledge, experience, and expertise to provide her patients with the most advanced and patient-specific treatment options. Dr. Rolle has worked in both academic and community rheumatology in the United States for the last 7 years and is experienced in the diagnosis and treatment of arthritis and other musculoskeletal diseases of the joints, muscles, and bones. Her more specific fields of interest include the treatment of rheumatoid arthritis, lupus vasculitis, pain disorders, osteoporosis, and enhancing the peri-pregnancy care of high-risk patients with rheumatic diseases. Her goal is to not only treat rheumatic conditions, but also prevent disability, improve quality of life, and recommend rehabilitative functions. She has served on multiple pharmaceutical advisory boards, including Pfizer and Cardinal Health, and is an active member of the Association of Women in Rheumatology and the Caribbean Association for Rheumatology. She is very excited to be here and very enthusiastic about being back home in her Bahamaland. So Dr. Rolle, thank you for joining us today, and we look forward to hearing from you. And to our audience, if there are any questions, you can raise your hand or you can place them in the chat. Thank you, Dr. Rolle.
Good morning, everybody, and thank you so much, Dr. Black. I am very thankful to be a part of your CME series. And so I hope we have a good discussion this morning, and I hope that everyone gets some benefit for it, no matter where you are in your medical career. So today, like Dr. Black mentioned, I'm going to be discussing psoriatic arthritis. And the reason I chose this topic is because, one, it is a very commonly misdiagnosed or just missed inflammatory arthritis. And two, it's a part of one of the major parts of the immune-mediated inflammatory diseases that of late has gotten a lot of attention because of new treatments and because of the various disease aspects that it presents in terms of the spectrum of presentations for this disease. So without further delay, just want to mention I have no financial disclosures. My learning objectives are to summarize the current understanding of pathogenesis of psoriatic arthritis and its extra-articular manifestations. We'll review the clinical features of psoriatic arthritis and hope to go over the clinical approach to both the evaluation and management of patients with psoriatic arthritis. And then we want to highlight the latest cytokine targeted treatment options. So what is psoriatic arthritis? like I had mentioned previously, it has a variable phenotypic expression, and that includes joint inflammation, it includes axial involvement, it includes psoriasis, as we know, skin involvement, and then the comorbidities that are highly associated with it. And that includes uveitis and inflammatory bowel disease, which I'll go through in much more detail later. So essentially, psoriatic arthritis is a part of the family of what we call seronegative spondyloarthritis. And this family, the arthritis is a chronic inflammatory arthritis, like, for example, rheumatoid arthritis. However, it's not associated with any type of identifiable antibodies. In psoriatic arthritis, we know that it's associated with psoriasis. And we know, like other chronic inflammatory arthritis, if it is left untreated, it can lead to long-term dysfunction because of disabilities and obviously adverse outcomes. What are some of the manifestations? Again, peripheral arthritis. That means small and large joints. Dactylitis, which means, and I don't know if you can see me, but diffuse digital involvement. And I'll explain that again as we go through the clinical manifestations. Enthesitis is where there is inflammation at any area where there's tendon attaching onto the bone. So common entheselial sites include the elbows, for example, the Achilles tendon where it attaches to the heel or the calcaneus. And finally, axial arthropathy, which many people are not aware of, and that's inclusive of the entire spine. Cervical mainly is primarily involved, along with lumbar disease and sacroiliac involvement. Approximately 15% of people with psoriasis develop psoriatic arthritis. So that means then that 85%, so overwhelming majority, do not. And so when a patient presents with me or when someone sends me a referral, yes, a patient might have active psoriasis, but not all of their joint complaints are related to an inflammatory feature or nature related to psoriatic arthritis. And so for these reasons, we have to really look at what are some of the clinical criteria before we diagnose someone as having psoriatic arthritis, and maybe hone into those clinical features, looking at laboratory workup, which are not diagnostic, but helps us to support inflammation, and then looking at radiographic findings that that the patient might have. Sorry about that. Appears in about, we know that psoriatic arthritis appears between the ages of 30 to 50, but can occur in childhood as well. And men and women are of equal risk. So the pathogenesis of psoriatic arthritis, like all autoimmune disease, are multifactorial. We know that HLA-B27, HLA-B08, HLA-B38, these play significant roles in the genesis of, particularly in axial psoriatic arthritis. So there's a genetic predisposition. There's also many environmental factors, including smoking, including exposures to bacterial and viral pathogens that lead to the development of oxidative stress. This leads to the cascade of proliferation in the innate and acquired immunity. And this leads to T cells and B cells flooding the synovium, leading to the production of cytokines. And the more common cytokines that we know that leads to harmful effect in psoriatic arthritis includes TNF, or tumor necrosis factor alpha, interleukin 17, interleukin 12 and 23 as well. So these are very common cytokines that now in today's world have become targets for therapies, as you will see as I go through the presentation. This leads to inflammation, and this inflammation is clinically manifested in peripheral joint disease as erosions, as extra bone formation, or we call it ossification. So we have synovitis, erosions in the peripheral arthritis. We have entheselial involvement with enthesitis and tendinitis, and then you have activation of skin disease. So this is just, I'm sorry, it's so busy. Again, talking about the contributors to what happens with psoriatic arthritis and with any autoimmune disease, those triggers like the genetic risk of HLA-B27, et cetera, that I just mentioned, leading to production of these inflammatory cytokines. But what I wanted to mention, if you go to the green part here, is that this manifestation, whether it's an immune reaction or inflammation, or if it's leading to angiogenesis and vasculitis, leads to a specific phenotype in terms of psoriatic arthritis. And this is how we differentiate this from other types of chronic inflammatory arthritis and even other types of seronegative spondyloarthritis within the of which psoriatic arthritis is part of the family. So mainly psoriatic arthritis is an asymmetrical leukoarthritis, and that simply means that it typically will involve, for example, if we have our hands, it will not, like rheumatoid arthritis, involve multiple MCPs, PIPs at the same time. So it has a preference for different types of joints, including big joints. There is a predilection for the distal interphalangeal joints. And as you know, the DIP can be involved in just mechanical osteoarthritis, but this is a different type of presentation of DIP involvement. Now, all of that being said, unfortunately, there are variants. And so we always have that in any disease. And so you can have symmetric polyarthritis, which happens in probably 15 or 20% of people, that can mimic that arthritis, or that presents in like rheumatoid arthritis. Axial involvement is not a feature in the typical rheumatoid arthritis, for example, but is a very common feature in psoriatic arthritis, particularly people who have had long-standing or extensive disease. And finally, looking at the radiographic features, because of increased osteoclastic activity, there's new bone formation. There are marginal erosions as opposed to erosions within the joint, which is in a typical rheumatoid arthritis. And so on x-rays, we see periostitis, syndesmophytes, which is new bone formation. And although not pathognomonic, we see pencil and cup deformities, and I'll show you that later. Here, again, are some of the features. I just want to hone on to the point so that you can see when we look at the joint and skin features for psoriatic arthritis, we know there are many types of presentations for psoriasis, but mainly the scaly pink salmon rash. And sometimes we can be fooled as to, we don't know, does this patient actually have psoriasis? And sometimes it is very difficult to diagnose because there can be times when the patient is in remission, when you might not have any clinical clue. But here are some things that we should always be have heightened awareness of. One, psoriatic arthritis can only involve the nails psoriasis, can only involve the nails at times. And so we have to look at different features like onycholysis, thickening, darkening of the nails. What feature that's commonly that's not looked at, or, that is mistaken, is having ridging in the nails or pitting in the nail. So it looks like little small pinholes inside the nails that you can look at the patient's nails and toes as well. Also looking for psoriasis post-auricular, behind the ears or in the umbilicus. And of course, having patches isolated into the scalp. Other features include, again, this distal involvement of the distal interphalangeal joints, and sometimes excessive destruction of those joints, which leads to complete whittling of the bone and actually deformities that lead to loss of or osteolysis of the bones in the hands. Looking at other features, sometimes we only see dactylitis, which is a sausage digits in the toes. That too is a very common feature that might be seen, but also overlooked. And then patients presenting with uveitis, which is inflammation in the eyes, scleral adjunction. And so these patients need to have a collaboration with the ophthalmologist, so that we can determine, what is the degree of inflammation in their eyes. In terms of imaging, the pencil and cup deformity that I had mentioned, and as you can see, there's a fuzzy type of osteolysis around the bone. There is in this area ankylosis, which is the bone is trying to join and fuse. And this is the typical pencil and cup deformity because of whittling of the bone, because of extensive erosions. And this X-ray just shows sacroiliitis, bilateral sacroiliitis that can occur. Now, just to mention again, the seronegative aspect simply means that antibodies are negative. There are no diagnostic antibodies like in rheumatoid arthritis or in lupus or in vasculitis that we can work up for psoriatic arthritis. We can test HLA-B27 positivity, but that does not give us a diagnosis. It just gives us a risk approximation of what the patient might have and what might be their prognostication further going on in future in terms of involvement of axial disease or eye involvement, etc. So what we look at when we look at labs is we try to rule out the other types of inflammatory arthritis. That's the main thing. And then we assess for inflammation. And so no inflammatory arthritis can be active without having active inflammatory markers like sedimentation rate or the CRP. And then ultimately, we will discuss the comorbidities. Psoriatic arthritis, like psoriasis, are associated with multiple comorbidities. And so that definitely needs to be highlighted. So diagnosis, again, we look as rheumatologists, and you can do this in your practice as well because it is very easy to do, looking at the CASPA criteria. And the patient has to have an inflammatory disease. So that means whether they have a peripheral arthritis, axial involvement, or endothelial involvement, that gives them certain points. The other points come from other categories, like if they have active current psoriasis, or maybe a personal family history of psoriasis, or a personal history, in the past of psoriasis. And then comes again this little thing of this nail psoriatic nail dystrophy, the pitting, the onycholysis, hyperkeratosis. We also include 1 point for having a negative rheumatoid factor test. And I just want to mention this, and this is where things become a little gray. Having a positive rheumatoid factor, even in psoriatic arthritis, does not mean that the patient doesn't have psoriatic arthritis, because up to 15-20% of patients can have a positive rheumatoid factor. So what we look again as at the clinical features, which increases the predictability, is this true psoriatic arthritis or another type of arthritis. And fourthly, we look at dactylitis again, or having a history of that, and then the radiographic evidence of newborn formation, ill-defined ossification, and marginal erosion, to help support our inflammatory arthritis. So looking at these pictures, these are just, again, some of the manifestations with severe nail involvement, umbilical involvement here, the dactylitis of that third digit. But I wanted to mention some specific features that might be helpful for the medical students in particular in helping to differentiate psoriatic arthritis from other types of inflammatory arthritis, because this is the main key. So I mentioned it being an asymmetrical oligoarthritis, meaning you have either less than 5 or small or large joints affected in an asymmetric distribution. But when that is involved, we also look at the predilection for what peripheral arthritis peripheral joints are involved. And for the hands in particular, again, that's the distal interphalangeal joints. So we call that the row pattern of involvement because there's sparing of the MCPs and the PIP joints. However, when we talk about dactylitis, we talk about the ray pattern, which means involvement of both the MCP, PIP, and DIP joint in terms of diffuse inflammation and swelling, and that could extend into the wrist. So looking at these patterns of the presentation of the arthritis is really important to help differentiate, to give you a clinical clue as to what's going on. In patients, we know that there can be definitely deformities with subluxations of the joint, and the subluxations can occur at the DIP, the PIP, or the MCP joint. It can occur at the large joints and in the feet in particular. When we talk about the symmetric polyarthritis, which is not the most common presentation, but it does occur, some people can have involvement of all their joints, and like I said, the MCPs included in that. And when we talk about arthritis mutilans, that I showed you a picture of that before, there's significant loss of bone. So there's literally whittling away of the bone, and so the patient loses both length and functionality of their digits, and that happens particularly in the hands. 30 to 50% of psoriatic patients, like I mentioned again, has enthesitis, and these typically occur at the Achilles tendon as well as the plantar fascia. So many persons might present with plantar fasciitis, and many of us are very are aware clinically of what that is. We know that that can happen for many reasons, but in psoriatic arthritis patients, it could be an initial presentation as well. So you have to keep your clinical acumen high. So radiographic changes. What are some of the radiographic changes? I've already discussed some of these. I know you see the small closed arrows, which is just showing some of that fuzzy osteolysis or periostitis, sorry, that I mentioned. Also, is showing closure of some of the joints like the PIP joints here in terms of involvement. These x-rays here show, this is a picture showing severe deformity because of acroosteolysis. So again, you lose length of the digit from severe deformity and whittling away or osteolysis of the bones. And then finally, again, the pencil and cup deformity because of subluxation. So some patients, we have to go beyond just doing x-rays, and so we do musculoskeletal ultrasounds. And so if that is something that you order or that you do in your clinical practice, it really is a useful tool to help you to diagnose, one, is this patient having an active inflammatory flare? Can you see changes that you might not be able to see on x-rays? And so that means looking at the tendons, et cetera, looking for Doppler, meaning active activity. So what you're seeing here is a coronal MRI image of the hand, which shows severe edema around the second flexor tendon, consistent with inflammation. But the initial images A, B, and C, you're showing musculoskeletal ultrasound imaging, which shows hypoechogenic areas around the flexor tendon. That's one, suggesting tenosynovitis. And then it shows here hypervascularity in the tendon, which suggests that there's active inflammation. This is simply a longitudinal view, and this is the, axial view of the tendon, showing significant areas of positive Doppler signaling. So moving on to the heel and the feet, what is seen here is calcification within the Achilles tendon. You can't see it very well, but it's not attached to the calcaneus, and that's typical of psoriatic arthritis involvement. And on ultrasound, you see significant osteophyte formation, as well as edema around the osteophytes. Again, osteophyte formation on longitudinal axis view, as well as inflammation or echogenicity within Kegel's fat pad here in the back. So there's definitely evidence of bony formation for which in which the Achilles tendon is attached to, which is causing, of course, not only inflammatory but also mechanical friction. And if you look at that with the Doppler ultrasound, again, you see this hypervascularity or positive Doppler signaling around the Achilles tendon. All of this is consistent with active endothelial involvement, active tendinitis, which is consistent with psoriatic arthritis. Here are some images looking at both the cervical spine as well as the lumbar spine in psoriatic arthritis. And in these views, we see things like bridging syndesmophytes, and I know you're probably familiar with that with ankylosing spondylitis. So again, that is not a pathognomonic feature, but a similar feature that is shared. There's also severe osteophyte formation and areas of spondylosis within the C-spine. And these are the bridging syndesmophytes in psoriatic arthritis that can be seen. And again, axial involvement is seen or can be seen in early disease from 5 to 25%, and in later disease up to 70% of patients. And so persons with psoriatic arthritis axial involvement usually have more long-standing disease, more active disease, more active skin disease as well. So everybody that presents, and they might present with axial disease initially as opposed to with peripheral arthritis. So this is when it becomes a little bit more tricky, because you have to determine, is this mechanical back disease? Is this just related to degenerative arthritis? Or does this have an inflammatory component to it? And so we've seen many patients go ahead and have, all these surgeries and stuff, and actually have active inflammatory axial disease, which is not treated with surgery, but instead needs to be treated with very dedicated biologic DMARDs. So again, looking at this axial, these pictures here, I'll go through that. We talked about the genetic predisposition. Again, we don't test this regularly, but there's a high association with HLA-B08 and B38. Unfortunately, with psoriatic arthritis, unlike ankylosing spondylitis or axial spondyloarthropathy related to, like non-radiographic axial SPA, unrelated to psoriasis, there's not a lot of inflammatory back symptoms. And by that I mean, people don't wake up with severe stiffness that improves with activity. So they can be asymptomatic. They might not have the typical features of sacroiliitis, which is usually isolated, really low back pelvic pain, or hip and groin involvement. So the most common place involved is the cervical spine and involvement of the facet joints. There's, like I said, less severe sacroiliitis, and there's non-marginal syndesmophytes and paravertebral ossification. How do we treat these people? So they're treated with NSAIDs, and I'll get into that a little later. But the reason why I want to bring it up now is because for all spondyloarthritis, whether that be psoriatic arthritis or otherwise, treatment with conventional DMARDs, meaning things like sulfasalazine, Plaquenil, etc., they do not work, so they're useless in this type of arthritis. You have to move on to biologics in order to get any efficacy, and all the corona studies and everything else shows that. So what I wanted to show you was that in this, we're looking at the SI joint on the right, which shows some sacroiliitis as well as some marginal erosions there on X-ray. And this is a MRI stir imaging showing again both sacral and iliac edema, suggestive of inflammation. And then on the T1 weighted images, again showing edema and inflammation in the pelvis or around the iliac and the sacral regions. So what are the extra-articular manifestations of psoriatic arthritis? We don't think about this a lot. We know about all the different things related to, for example, RA and many of the other connective tissue diseases. But yes, apart from, skin disease, there's a high risk for inflammatory bowel disease. And that means, involvement with Crohn's or ulcerative colitis, and then mainly uveitis in terms of ocular involvement. And again, we have, this activation about the adaptive and innate immunity involving influx of all these cells, whether it be neutrophils, macrophages, activation of the T cells, and leading to the development of these pro-inflammatory cytokines like TNF-alpha, interleukin-2 that leads to inflammation. And this is the same process that leads to gut dysbiosis, which involves development of inflammatory bowel disease and active inflammatory eye disease. So the alteration in the microbiome in the gut, we look at interleukin 22 and interleukin 17. And the reason why I bring these up, because I know in the normal, as you go about your daily life, these are not things that we think about in terms of how do we treat? But the reason why I bring this up, because I want to focus your mind or get you focused on why we use these targeted therapies, and why when you see like interleukin 23, interleukin 17, interleukin 12, or TNF alpha, why these are used to treat certain diseases. So we look at what are the risk factors for persons with psoriasis and psoriatic arthritis. They have a 1 to fold increased risk of inflammatory bowel disease compared to general population. And it goes as high as being up to 42% macroscopically, and up to 58% histologically, meaning having microscopic inflammation. And we know that inflammatory bowel disease is also more common in patients who have more severe psoriatic arthritis and axial psoriasis as well. So ocular disease, strong HLA-B27 association. And again, because of these influx of T helper cells, interleukin 17, interleukin 23, the clinical manifestation is acute anterior uveitis most of the time, and it's a prevalence as high as 25%. So how do we know what these patients have? We might not know. The patient might just mention briefly that they have recurrent episodes of red eyes or pain looking in the light. We call that photophobia. But usually it will involve both eyes in the cases of our psoriatic arthritis patients, and they're usually chronic and a relapsing cause. So these patients definitely need to be seen by ophthalmologists. These patients need to be seen by an ophthalmologist, and they need to be monitored on a regular basis. And this is because unfortunately, acute anterior uveitis, if it's recurrent, severe, can actually lead to blindness. So how do we treat these patients? Mild topical steroids, typically given by the eye doctor. But when you have persistent recurrent disease, that's when we come in with more of the the conventional synthetic DMARDs like methotrexate and or targeted therapies like the biologics. And so these patients, again, should be put on, we should have a high clinical acumen and suspicion when we see that they might be complaining of eye issues, and they might not have any visual acuity loss, but they might talk about having intermittent flares of having red eye. They should be definitely one of those persons that need to, these patients need to be referred, need to be seen by an eye doctor, and you have a, combined care. So we talk about the comorbidities in psoriatic arthritis, and there are many. As you know, with psoriasis patients, there's increased risk for depression and things like fibromyalgia. But the other comorbidities that we are very commonly aware of, but we need to manage more aggressively, is their risk for diabetes and cardiovascular disease, because many of the patients with psoriatic arthritis are overweight. Also, I mentioned this before, obviously, the uveitis, inflammatory bowel disease, but because of increased and ongoing inflammation, there's also increased risk of bone loss. So osteoporosis is one of those key things that we need to look for as well. So treatment options. I wanted to delve into this, so we're getting there, people. Treatment options, there are many. So non-pharmacologic options. Of course, physical therapy to help strengthen, to improve range of motion, to give them some degree of functionality back. occupational therapy. We try to make them stop smoking again. All those things increase oxidative stress and inflammation. Weight loss, massage therapy as indicated, and exercise to just for the overall well-being and health. In terms of diet, I wouldn't delve into this, but of course, trying to reduce an inflammatory type diet, which means the diet is high in sugar. So, we found that the Mediterranean diet is probably one of the best diets to adopt. That's high in olive oil, low in red meat, high in white lean meat, and fruits and vegetables. So those are things that we should encourage our patients to do. Now, for symptomatic patients and what we want to do in terms of, we can start off with NSAIDs if there's no contraindication. Of course, we use steroids, particularly for peripheral arthritis flares, and then local steroid injections where indicated. Now, small molecules or oral small molecules, OSM, is what I was talking about when we talk about conventional synthetic disease-modifying anti-rheumatic drugs or DMARDs. And, we've used methotrexate. It's been tried and true. We've used it for over 50 plus years now. So we use it a lot for the peripheral arthritis. But again, I just want to mention that when you see your patient or if you have your patient referred to the rheumatologist, the methotrexate only works for certain things. And I'll get back when we get into the algorithm of how to treat these patients. Sulfasalazine is one of the drugs that we also use early on for patients that might have mild disease. Cyclosporin, not very often. Leflunomide is another very long traditional DMARD that I use a lot, but not often. Apremilast is good for those patients who have increased risk of infection, but it is very costly. So not a very not a very common option for those persons who are out-of-pocket payers. So going now to those targeted therapies that I mentioned, and you don't have to, the main thing is, it's not about knowing every drug in the world to treat it because there's a new drug coming out every day practically. But it's about understanding why we're using certain targeted therapies and what the options that are available for the patients. And again, not all of these options are available in terms of can be cost prohibitive, but these are things that we are trying to get through. Hopefully, we have one or two on the formulary so that the patients who have really severe disease that cannot be controlled with anything else, we need steroid sparing. There are many patients that need these drugs. And so we start with the TNF inhibitors, and there are many of them. The list goes on. But more common ones we use are etanercept and adalimumab, or more commonly Humira and Enbrel, if you're familiar with those. Interleukin 12 and 23 inhibitors like Stelara, ustekinumab, interleukin 17 inhibitors like Taltz and Cosentyx, and I'm sorry you've seen all these on TV. Interleukin 23 inhibitors by themselves like Tremfya and Skyrizi, CTLA-4 injection or infusions like abatacept and JAK inhibitors. And I know these might sound far-fetched in between, but I've used these for more than 15 years now. These drugs are tried and true. Most of them work very well. We have to balance the risk of course, infection and any adverse outcome with the benefits for the patients. And I know you might say, well, it's only an inflammatory arthritis, but for many patients, they lose their functionality, the ability to use their hands and ability to walk. And we have these drugs now that can prevent, having such severe morbidity from these diseases. And so it's very important. That's why to recognize the disease, to recognize the comorbidities that your patients might have, and to recognize, does this patient need to be referred early so that they can get started on these type of medications. So I'm sorry that this is so busy, but this is a treatment algorithm, just going through some of the phenotypic presentations of psoriatic arthritis that I had mentioned. We talked about the axial involvement. We talked about the enthesitis, and I just want to mention if you look in, both areas, again, conventional DMARDs are not warranted. They don't work. So we don't waste time when you have its axial involvement and enthesial involvement, we move right into biologics like the TNF inhibitors and interleukin-17 inhibitors. That's typically what we start with, or whatever the insurance will pay for, or whatever we can get. And then we progress on to those other drugs that I had mentioned, okay? And I know you see something here like TS, DMARDs, and that is, we're just talking about more the traditional synthetic DMARDs that we use, like, for example, the JAK inhibitors, like Xeljanz, etc., if patients fail some of those other medications. Now, going back to the peripheral arthritis, so this is what we see more. That, as well as the dactylitis. Again, we use some of those drugs that I had mentioned, like the methotrexate. I just want to keep mentioning that because it is very helpful, particularly for controlling peripheral arthritis, dactylitis, and skin involvement in psoriatic arthritis and psoriasis. And why is this important? Again, there are many patients who will not respond to, for example, even in skin involvement, light therapy, topical therapy. And these patients deserve an opportunity to be on medications to control their disease. So this is where these medications come in. And again, the biologics and going on to these other types of DMARD therapies. So how do we measure the response to treatment? We've talked a lot about treatment. How do we know the treatment is working? Obviously, clinical improvement, right? We want a patient to, say they feel better, they're looking better in terms of their skin, they have less swelling, they have more functionality. And so there is a way that we can measure this. And sometimes this might be difficult in your clinical workday, but there is the Leeds Minimal Disease Activity Score. That's pretty easy, looking at the skin, the joints, and the presence of enthesitis. So you get scores achieved when 5 of the 7 criteria are met, meaning that your tender joint count is less than 1, your swollen joint count is less than 1. And when we talk about the PASI, that is an assessment of your skin involvement in psoriatic arthritis. And so we look at either the body surface area, meaning how much is involved with its skin. We usually use the hand as 1%. And so whatever the hand covers is 1%, is how much surface area is involved. We look at the patient assessment, patient pain, visual analog score. We look at the global disease activity of the patient, health assessment questionnaire, and we look at tender and enthesial points as well. So these are things that I, as a rheumatologist, can practice, so that we can monitor to see whether the progression of treatment, is actually having some benefit for our patient. But more realistically, if that is not something that can be done, say, in a regular visit, we definitely need to make sure that the patient's comorbidities are being evaluated, make sure that there's not active inflammation. And we do that by looking at the labs on an intermittent basis, particularly if they're on DMARD therapy with methotrexate. With a biologic therapy, most patients are not aware of this, but you do not really have to monitor liver and kidney disease function because they really do not affect those organs. So that's one good thing, right? So we're looking at the inflammation in the joints. We're looking at tenderness in the joints. We're looking at patients' functionality. Are they able to get back to normal activities? Can they go back to exercising and doing their regular activity? Or even more importantly, just going back to being able to function in their home and workplace. And so these are important things because as we treat the patient, we aim to treat the whole patient, not just give them medications, but we want them to live a highly productive and functional life where they can get back to doing things that they want to do. So again, beyond medications, and I'm wrapping up here. Low impact exercises, physical therapy, where we can learn ways to improve movement and decrease pain, occupational therapy, complementary medicine. And of course, we have our natural remedies. I have patients who are on like 15 vitamins. Why? With our Bahamian diet, but they do it. And I do believe in natural and holistic medicine, but you have to have it in, everything within a certain range of what might be beneficial beneficial versus what might not, compared, especially the medications that the patient might be on, like the DMARD or biologics. But there has been some benefit shown in certain studies with apple cider vinegar, tea tree oil, turmeric, and curcumin, and aloe vera. And again, I won't fail to mention the importance of a healthy diet and reducing stress in any which way you can. So in summary, how do we manage these patients? I think it's a multidisciplinary approach that we need to adapt, meaning that all of us need to be involved, from the general practitioners, from the family medicine doctors, internists, the specialists, and that includes myself. That might include orthopedics, because some of these patients might need a new joint, and that happens a lot, particularly large joint, hip and knee or involvement. Also, remember we talked about the comorbidities. So a multidisciplinary team approach, and that means one, early recognition, knowing that, hey, this person might present with joint pain, but they also have some issues going on with their bowel. So there's a risk for inflammatory bowel disease or a risk of uveitis. So early referral to specialists, as indicated. Early diagnosis, 2T2T, sorry, means treat to target. And that's targeting some of those things that I had mentioned to get the patient. The goal is no longer to get the patient feeling well. This is why we are no longer just prescribing steroids and then just, let the patient stay on steroids for years and years, not managed, not monitoring for developing the disease. So when we treat the target, we are trying to use, again, those very specific cytokines therapies to block the cytokines that's causing damage and that will lead to destruction or can lead to end organ damage, whether that be eye disease, bowel disease, axial involvement. And then also we need minimal disease activity or remission. This is always the goal. And, what do we find as remission? We hear that a lot with cancer therapy, but we have adopted that same, the goal in the rheumatology world. And I'm hoping that today you might start to think on that in that vein as well. The goal is that we want the patient to have disease-free activity, meaning where they on their medications, but they don't have active flares. We don't have to use frequent pulsing with steroids or any steroids at all, if that's possible. And that the patient's living a highly functional life. And so that's the goal. And we want to address and manage and monitor comorbidities. Again, this is very important because in treating the whole patient, again, patients that have chronic inflammatory conditions are at much higher risk for cardiovascular disease. And then because of some of the medications we use, whether that be long-term steroids or not, that we try to avoid, but in some cases have been used. So, risk for diabetes, etc. And then lifestyle modifications like smoking cessation, weight reduction, and again, physical therapy, occupational therapy, and all those things that help to enhance the overall care of the patient. Here are my references. And again, thank you so much for your attention. If you have any questions, please let me know.
Thank you very much, Dr. Rolle, for that presentation. Thank you for bringing some clarity, what can often be a very, very difficult diagnosis. I'm waiting to see if there are any questions in the chat. That being said, while we wait, I wanted to ask, from my own personal perspective, the last case of psoriatic arthritis that I diagnosed was actually on a routine workup in a patient who came in with symptoms of anemia and ended up having inflammatory bowel disease. And we came to the diagnosis, and in taking the history, there was this arthritic history that the patient didn't volunteer but attributed it to lifestyle. So what I wanted to ask is this a diagnosis that is being missed, and how common is this diagnosis in our Bahamian population given the association of inflammation and obesity, based on what you've said?
Yeah, Dr. Black, that's an excellent question. It definitely is being missed very many times. And like I said, for many reasons, because the disease not always overwhelmingly manifests as what we typically would say is an inflammatory arthritis. For example, if in rheumatoid arthritis, we have the severe peripheral arthritis. These patients can present with episodic flares. So, it's most of the times you're after the fact, you're not seeing the patient. They might have had painful swelling of the knee that resolved, or they might have pain and swelling in the elbow and or difficulty straightening their arms, and might have the sequela of long-term difficulty doing, straightening their arm, but then again, did not give you that presentation that there was swelling, there was pain at the, at where the elbow, or even I see this a lot. Patients come to me with a history, they have an enlarged Achilles tendon, right? It's not swollen, not painful anymore, but then they had a history 2 or 3 years ago of it being painful for months, and or a middle toe that was enlarged and swollen, the entire toe. They'll say was so fat. These are things that we miss. And then what makes it even more difficult is that the arthritis can precede the onset of the psoriasis. I know that sounds strange, but it can. What makes it easier to difficult is when you delve into the history and find out, hey, this person does have psoriasis. And again, the psoriasis might not be as obvious as a patient coming in with manifestation of like 50% plaques over their body. They could have involvement of just the umbilicus. They could have involvement of just nail dystrophy, or they could have patches just behind the ears. And this is where it becomes a little bit more complicated. And this is why when you see the patients, I know sometimes time allowing, obviously, but you have to kind of probe into the history of what's been going on with the patient. And again, even with back disease, many people say they have back, pain in their back. But the question is this inflammatory pain? Is this persistent chronic pain? Is this pain that's out of proportion to what might be typical for just mechanical arthritis or radiculopathy? So you have to kind of delve into the different history and ask them about, have you ever had where you can't look into the sun? Have you had redness in your eye anytime, where you didn't have conjunctivitis and your doctor just gave you some steroid for it, and those are the type of things that will help to reveal. Now, what also is helpful is a family history. Some people have a history of psoriasis in their mom, their dad, their brother, sister, whatever. Some people have a history of inflammatory bowel disease like Crohn's, ulcerative colitis. They might say that they had a history of colitis or these bloody stools years ago that resolved, So these are the type of things. So it does really require a little bit higher acumen. And this is why I said it's okay to refer the person early, because, you have to sometimes, like almost like a detective, get all these clues to come up with what you think might be the most appropriate. And I mentioned that there are many overlaps, because even you saying that, right? The patient might have psoriasis, might have arthritis, but you said they also had inflammatory bowel disease. Who's to say that the patient doesn't have IBD-related arthropathy, right? And just happen to have psoriasis. So it's kind of difficult. And this is why you have to look at the imaging as well as part of this workup to see, what is this presentation related to the psoriatic arthritis, or is it related to mechanical arthritis with somebody who just has IBD and psoriasis, etc. So that's when it becomes a little bit more complex. But to answer your last question, I believe you mentioned what might be the incidence in the Bahamas. And I do think we have a lot of undiagnosed seronegative arthritis, whether that be from psoriasis or what we call non-radiographic axial spondylomas. There's a lot. And unfortunately, I cannot give you a precise incidence or of this because we don't have a registry. I've been trying, we need to work together to try to get a registry of our rheumatic diseases. I've been trying more so with the lupus patients, but hopefully once we get that on board, we can start to gather that information on the different types of arthritis like rheumatoid, like the spondyloarthropathies, inclusive of psoriatic arthritis as well.
Thank you. And I don't see any additional questions in the chat, but this is often a very difficult diagnosis to make, as you've highlighted, as well as early referral, like you said, is, what you recommend. But in closing, do you have, outside of, having a high index of suspicion, do you have any tips from what you have noticed since you've been practicing here of high yield things that we might notice on examination that increases that likelihood that this patient may have psoriatic arthritis or collagen vascular disease and warrant early referral?
Sure. In our Bahamian population, like I mentioned, I do think we have a disproportionately high number. I don't know if it's because of our genetic pool of what I think is seronegative spondyloarthropathies, whether that be peripheral or more so than axial involvement. And so things that you all can look at that I think are beneficial, right? Even if it's DIP involvement, and yes, we know that predilection for evidence nodes associated with osteoarthritis is pretty common, but I'm talking about when you see more significant deformities, for example, subluxations in joints, meaning joints that are completely out of place, or the patient complains of, the main keywords are swelling, stiffness, particularly in the mornings when they wake up, that's beyond 30 minutes. That's more consistent with an inflammatory picture. I would say, even though we don't have a specific antibody, we have to start somewhere, right? So let's at least check the SED rate, erythrocytes and sedimentation rate. Let's check the CRP. Let's check to rule out basic things before you, if you want to do that before you refer rheumatoid arthritis. Again, most of these patients, in terms of their age and how they present, will have low risk of connective tissue disease. But if you want to check an ANA direct, that's fine too. So we check those things, say those things are negative, but the inflammatory markers are positive. Then we know we're dealing with an inflammatory type of arthritis. And so definitely this patient deserves now more workup. And part of that workup includes, again, we start with our x-rays. And starting with our x-rays, some of the features that I mentioned, like marginal erosions, like extra bone formation that is out of proportion than what you would see in typical arthritis, and some of those deformities that I had mentioned before. But more importantly, if you don't see, because sometimes early on, you're not going to see all those deformities that I mentioned. There are other things like I had shown you in the presentation, like musculoskeletal ultrasound, where we can do Doppler studies, etc., looking at tenosynovitis and looking at if there's possible hypervascularity in the areas that might be affecting the patient. And then if you can't do that or have access to that, there's also options for MRIs and CT scans if it's cost, if it is not cost prohibitive. So those are some of the things that you can do. And then finally, one test, and I'm not saying you do this in everybody in the, that comes to you, but if the person has what we might suspect as inflammatory arthritis, and I know most of us jump to the conclusion of gout, but we have to remember gout, yes, affects certain population, but if you're dealing with people who are younger, it is unlikely gout, particularly if it's women who are premenopausal. And so we have to look at things like other things I forgot to mention in the lab, like uric acid, et cetera, looking for things like that, and looking for evidence on x-rays of pseudo-gout, like calciocalcinosis, et cetera. But what I was going to say was, in terms of treatment, if we find that the patient improves, most people with any type of arthritis will improve with an NSAIDs, but if you give them steroids and they have to keep coming back for pulse steroids, then that suggests that that's an inflammatory component and the patient needs to, again, be maybe considered for more aggressive, more maintenance steroid sparing therapy, like I had mentioned, methotrexate and the like. And, you could always give me a call, get a chat, and, so that if the patient needs to be seen earlier, you could, triage that patient to be seen sooner than later.
Well, thank you very much, Dr. Rolle. Thank you for joining us today, and thank you for sharing with us.
You're very welcome. Thank you so much for your time and attention, everybody.
Okay, and it's 9 o'clock, so we will start closing out the meeting now. Thank you very much to our audience, and thank you to Dr. Darren Halliday, our technical support. And just as a reminder, this month is university exams, so there's a lot going on. We will take a break from CME until August, as in July, we have lots of university celebration activities. So I encourage everyone to participate in the celebratory activities with the university, and we will see each other again in August. So have a wonderful day, everyone, and thank you.
Thank you.
Thank you, Dr. Rolle. Bye.